Hey everyone, welcome back. Dr. Erik here from MedBetter Health, where we help caregivers who take care of persons living with dementia. Today I'm going to talk about a very important topic. A lot of people ask me, Dr. Erik, can you help us understand some of the new treatments out there for Alzheimer's disease? If you're one of those people, you're in the right place. Let's go. So, really, just to let you know, currently there's over 140 new medications that are being studied in clinical trials. And that's a great thing for you. But there's two medications that actually just came out in 2023 and 2024. One of the names is Lecanemab. That's this medication right over here, came out in 2023. And the other one is Donanemab. That came out in 2024. Great, Dr. Erik. But what are they? What do they do? Well, they're actually called monoclonal antibodies. What does that mean? Dr. Erik, we're not in medical school. Can you help us understand? Well, let's take a look. You see this over here? This is not looking nice. These are dark plaques. And what these plaques do is they actually prevent you from having good memory in layman terms, right? They're one of the causes, they're thought to cause the progression of memory loss. Okay, so, interesting. These plaques are no good. Therefore, what should we try to do? Well, what if we actually try to remove these plaques? And I have a slide over here, right? You see these plaques? What if we try to remove these plaques with what? With these anti-amyloid plaque treatments. Interesting. With these anti-amyloid treatments, so what does that do? Well, what if these anti-amyloid treatments are going to take these plaques and make them disappear and make them go away? What will actually happen? Well, the theory is, and what we're studying and what we're finding is that they actually slow the cognitive decline by about 30%. That's what the articles are saying. By 30%, it slows someone's memory from getting worse and worse if we do what? If we remove the plaques. Okay, so that's interesting. Very, very interesting. So Dr. Erik, you're saying there's two drugs, Donanemab, Lecanemab, and they slow the progression disease by 30%. Okay, well, how do we get them? Who is it for? Well, that's the interesting question. First of all, this is for one category is mild cognitive impairment. So someone who doesn't have full-blown dementia or moderate dementia, someone who just has mild cognitive impairment. That's kind of like phase 1. Then it's also for early stage dementia, for people who have mild, early stage dementia. So if your loved one has moderate or severe dementia, this medication will not be used for them or will not be beneficial. So just remember, who is it for? Someone who has mild cognitive impairment or early stage dementia. Okay? All right, so we've got that far. All right, very nice. So these medications, Donanemab, how do I take it? Is it a drug? Is it something that I take twice a day? No, it's actually an infusion. Really? What does that mean? Well, you go to a specific clinic, they put in an IV, right? And through that IV, you're getting that medication into your veins. Oh, okay. And how often do I need it? Well, for Donanemab, it's once every 4 weeks. And for Lecanemab, it's once every 2 weeks. And Dr. Erik, is this just in clinical trials or is it FDA approved? It's actually FDA approved. All right, so you're with me right now. What else do I need to do? Well, one thing you need to do is you need to make sure your neurologist is going to confirm that your loved one or the person living with dementia actually has amyloid in the brain before starting. Does that mean they have to do a sample biopsy of my brain? No. Through imaging and other modalities that are non-invasive, there needs to be a confirmation that the amyloid is actually there. Because if there's no amyloid there, why are we trying to remove amyloid where it's not there, right? Doesn't make sense. So, okay, Dr. Erik, everything has a downside. You just told me the good stuff. You just told me that 30%, up to 30% slow progression of disease. You just told me it's for mild cognitive impairment or early onset dementia. Okay, and you just told me I need to get an infusion, but what's the downside, right? What happens? Well, think about it this way. This is a blood vessel right over here. Now, within the blood vessel, what do you have? You have these amyloid plaques. Now, they're also right inside here. What happens when you start breaking down the elements of a wall, right? The wall starts to not get as strong as before. So what we have very often happen is something called ARIA. ARIA is known as amyloid-related imaging abnormalities, right? Imaging abnormalities. Dr. Erik, well, what do you mean? Well, typically what happens is you can get either leakage from those vessels, and so you're getting an edema, a swelling in the brain, or you can get even something called hemorrhage, a little bit of bleeding in the brain, or a lot, depending, right? And there's different studies about that. So if we take a look, well, what is ARIA? Typically temporary swelling in the areas of the brain, may involve small spots of bleeding as well. Okay, what else? Symptoms. Very often a person could be asymptomatic. They're not feeling anything. They're not even knowing they're having this. But it could also include headache, dizziness, nausea, confusion, vision changes. So it depends on how much of these changes are going on. Now, is it worse in certain people? Yes. We do genetic testing in certain people. And if we find that a person has this gene over here, right, then these folks are at an increased risk of ARIA. So the protocol that the FDA encourages is that you do genetic testing prior to treatment to make sure that, hey, if someone does have that gene expression, then they're at a higher risk, so that we have that conversation with you and the family. The other thing is, when you're getting these medications, it does require monitoring. What does it mean, monitoring? Well, one of the things that you need to do is regular MRI scans. Why? Because we want to do imaging of the brain to see, hey, are these ARIA, are these abnormal changes related to the treatment? Are we seeing it with the edema and the hemorrhage in the MRI, or is it not there? So really constant monitoring of that. So two main side effects, and you can have infusion-related reactions, which are usually at the beginning of treatment. Sometimes you feel like a little bit of a virus hit you, right? But this is usually short-lasting. And then obviously what we talked about is the ARIA, which is these leaky blood vessels that happen. So kind of take-home thoughts for the folks listening. I'm not saying to scare you, oh my God, there's ARIA, there's these changes, there's edema, don't do it. No, this is just a conversation that you have with your neurologist, right? Because this medication does work. And so you definitely want to have a conversation with your neurologist. So take home thoughts from the studies. Majority of people who were treated with these meds, they had something called mild cognitive impairment. That's pre-dementia, right? That's not a diagnosis of dementia. That's a little bit mild impairment cognitively. Okay. Now, most patients eligible for treatment are likely in primary care and may not see a specialist until too late. That means if you're starting to notice that you're having memory problems, don't wait too long. See a neurologist so that you could actually see if you could get this early on, because you won't be able to get it if the progression of the disease is later on. If you have moderate or severe disease, you won't be able to get it. Now, studies actually show, as I mentioned before, at 27 to 28, close to 30% slowdown in the rate of the disease. That's huge. 30% is a huge number. And that's where you got to sit down with your neurologist and go through the risks versus the benefits of this treatment, right? That's where you talk about that. And I'll tell you that very, very important to understand that you need to get the testing, you need to get the MRI. So what message can I give you? If you have a good neurologist, if you have someone who understands this, it's better to have that conversation early on and not later on in disease. And what we do here at MedBetter Health, we are actually part of a new program from Medicare called the Guide Model. So if you're listening to this and you're like, wow, I wish someone else could actually explain these things to me in detail like Dr. Erik did. We have a whole team of Dr. Eriks as part of this Medicare program that if you qualify, covered by Medicare, Me and my team are able to speak to you on a monthly basis, connect you with neurologists, support you with different resources. Even if you're exhausted and you need a break, we're able through Medicare to cover a private duty home care to be in your home to take care of your person living with dementia so that you could catch a break. And the best part about this is it's free. If you have traditional Medicare and your person has a dementia diagnosis, Medicare covers this program. So if you're interested and you like what you're hearing, I'm going to put a website right over here. You'll be able to see it. I want you to go to that website. There's a video, it's about 5 minutes, that talks about what the guide model is. And then there's a little application. Literally, it'll take you 5 minutes to fill out. Once we receive it, we'll reach out to you and help you each step of the way. A pleasure talking to you, and I'll talk to you next time.